Alright guys, another JG Extra. This time, all credit goes to Dr. Brown for showing me how to do the downtown James Brown method of a posterior epistaxis packing, or posterior nosebleed packing. So, um, background, why we're doing this one, I had a 55-year-old or 53-year-old female who came in with a nosebleed. Stephen tried some interventions in triage. He tried putting some gauze, then using Afrin, putting a rapid rhino. But when she got into the room, she was still bleeding. So I tried to leave the rhino in place, and then I applied the tongue depressor vice grip, which credit goes to Dr. Parson for showing me how to make that. And then that didn't work, so then I tried soaking the rapid rhino with Afrin and putting the tongue depressor vice grip again. So you may ask, what the heck is this tongue depressor vice grip? Essentially, you just take two tongue depressors, tape them together near the midpoint, and once you do that, it'll end up looking something like this. And once you have that, you can slap it onto your patient's nose. They might feel kind of like where they're wearing a dunce cap or something, but it is pretty effective. What I tell the patient once I put it on is, do not touch it until I come back. I will take it off. Leave them sitting up and forward so that they're not swallowing blood. Tell them to spit any blood that's running down the back of their mouth out and spit it out into a little bin. So back to our patient. She failed all of that. So we're thinking more likely a posterior bleed. You can try the Rapid Rhino anterior posterior pack. This is essentially just a little bit longer. We used a 7.5. So we did do that. She failed. Dr. Brown asked for the double balloon rhino, but that wasn't available in our ED. So what is the double balloon rhino? Here's essentially a picture that essentially there's just two balloons. Another picture of it right here. So since she didn't, since we weren't able to control the bleeding with that, we got ready to do the downtown method for the posterior packing. So all of the supplies that you'll need are essentially right here in this picture. Okay, you're going to need bayonet forceps. We'll show a close-up of it in a second. A nice little mix here of what we mixed it with. Essentially, we emptied out half the bottle of Afrin, and we replaced that with a mixture of Lido with Epi, and so it's essentially about a 1-to-1 mixture. And then you can get a Foley catheter, a small Foley catheter. We used a 14 French, shears, vaseline gauze, and a nasal speculum. An option if you don't have the vaseline gauze, I read in Tintinelli's, is just packing, like you're packing for an IND, and you coat that with bacitracin. So a little close-up of the bayonet forceps. The nice thing here about the bayonet forceps, and the reason that Dr. Brown wanted to use these, is because it allows you to have a nice line of sight down the forceps here, whereas your hand is right here applying the pressure, but you can still see where you're going with the tip of the forceps there. And so that's why it's an important reason to have these specific kind of forceps for this procedure. So, step one is to cut your gauze. The reason being is because we didn't have the nice long gauze that Dr. Brown was used to. Essentially, he was asking for gauze that's as long as possible, but only about an inch or so wide. So what we did was we took the 4x4s and we cut them in this pattern that you see here. You go one line down this way, one over, and then one back up, so that from your 4x4 you essentially get a nice little strip. And this strip ended up being about probably, I want to say, a foot or so. And so what we did was we tied a few of them together to make a long strip that was probably around 4 or 5 feet long. And actually, this brings up, I forgot to mention, the actual true step one is to have the patient blow out as much clot as possible. By this time that we were getting ready to do this, our patient blew out a clot the size of probably like a tennis ball. It's pretty nasty. So anyways, first, our next step, and by the way, the pictures that you see here, we showed the patient. She was okay with us taking pictures. We told her we would treat the same way, regardless of not if we let the pictures and we got consent, etc. Anyways, The next step is to squirt in your mixture of Afrin, lidocaine, epinephrine to anesthetize, but also to try to help constrict the vessels a little bit. Next step was to further clean and inspect. What you see here, Dr. Brown is doing is taking the bayonet forceps and just trying to use some gauze to soak up as much blood as possible so we can try to see what's going on in there. And so what we saw was no blood in the anterior portion of the nose, so we kind of more confirmed that this was a posterior bleed. So this Foley's point is actually a little bit early. It should be on the next slide. So anyways, insert the Foley is the next step. And going back to that bullet point is how far do you need to insert the Foley? Essentially, when you are inserting the Foley, you're going to have the patient open their mouth, look into the mouth, and then you should be able to see the tip of the Foley sitting at the back of the throat. And you'll know that you're far enough. So the next step is to start inserting the Vaseline gauze. And you just start packing it back into the nasal cavity or the nair and just start filling up as much of the space as possible with your Vaseline gauze. Okay, more packing you can see here. This is actually just a quick video.
Okay, slow deep breaths.
Okay, just Dr. Brown putting in the packing. So, this is a good picture demonstrating, like I said, how you can see down the bayonet forceps your line of sight of where you're going with your gauze and everything. So, next step, once you've packed the nair pretty tight with the gauze, is to fill the Foley balloon, and then you're gonna use your syringe. You fill the balloon. They're going to feel the balloon inflating. They're going to feel it in the back of their throat. And then you're going to gently pull the Foley back so that the balloon essentially comes up the throat and more into the nose to lodge where it needs to be. And once that happened, the bleeding stopped in our patient. So then you're going to secure the Foley somehow so that it's not moving everywhere. It can't go further back or come out. And essentially what you've created is this right here. You have, remember, like I said, you're going to insert the Foley all the way down here so you can see when they open the mouth, you can see the tip of the Foley. But then once you have packed the nair tight with the Vaseline gauze, then you're going to pull the Foley back this way so that the balloon actually tamponades where the source of the bleed is. Another shot again of just essentially the process of filling up the nose. And so my patient did rebleed after Dr. Brown had left and we were still getting ready to transfer her out to ENT care. So what we did was we checked the Foley. Foley was, the balloon was still holding air, but we noticed that the tip had migrated back down the throat. So those are the two main things that I would say to check. Balloon, whether or not it's still intact, and has the tip migrated anywhere. So we secured it better after this, and she stopped bleeding again. So the next few slides are just a quick review on nosebleeds. If you want to continue listening, go ahead. If not, the kind of new stuff is done. So just a quick picture. Remember the Kiesel box plexus is the most common site of the anterior bleeds. A couple of different arteries feed into that. Many different causes of nosebleeds, digital trauma being the most, but also remember to ask about cocaine use or blood clotting problems. IV access, of course, is important in any patient with a bleed, but even if the bleed seems kind of minor, if nothing else, you can give some pain medicine. Remember to check their INR, see if that's one of the possible causes. And the point of anterior posterior. So when I called the accepting physician, I think it was Las Palmas where we transferred her for ENT, I mentioned to him how we were sending him a patient with a posterior nosebleed. First question out of his mouth was, how do you know it's a posterior bleed? And essentially I just said, well, we tried a bunch of different methods to try to control the anterior bleed, but those weren't working, so now we're suspecting a posterior, and he said, okay. And that's kind of what Tintinelli describes, like you'll see in a second. So in the future, if you're not an academic institution, some things you might want to make sure that your ED has before the poop hits the fan in a patient who comes in with a nosebleed, or your list here, what you see, just kind of many of the equipment that we had: nasal speculum, suction, pledgets, Afrin, lidocaine, silver nitrate swabs, materials for packing, and so on. So, what's the best way to examine the patient with a nosebleed? Sniffing position, so they're not swallowing all the blood. And then once you get your nasal speculum, open it in a cephalad to caudad manner so that you can get a good view of the Kieselblatt's plexus. Remember to ask the patient to blow their nose hard, because if you're going to apply topical vasoconstrictors, if there's clot there, it's not going to reach the mucosa. So once you apply your vasoconstrictors, remember to wait about 10 to 15 minutes to see if that takes any effect. And my trick is to, like I said, apply the tongue depressor during this time. Usually, pressure and plus or vasoconstrictors is enough, but sometimes they're not. So if they're not, you can try another attempt of direct pressure. If this fails, then you can move on to chemical cautery, silver nitrate being the most common, but remember you need to have a relatively dry area, soak up as much blood as you can, otherwise it's not going to work. And before you do, you can anesthetize with the mix of the Afrin and lidocaine stuff. And only do they recommend only doing the silver nitrate if you can actually see your source of bleed. You don't want to be basically hitting the nair with napalm and just scorching everything, because you're going to probably cause more damage than good. And remember never to apply silver nitrate to both sides of the septum, as this can cause necrosis and other complications. Remember, there are anterior packs, like we mentioned, the Rapid Rhino. You can soak them either with water or your mix of Afrin. And how far or how much do you inflate the balloon for your Rapid Rhino? Just enough so it's firm but not tense. Then, like I said, Tintinelli says that if there is failure to control hemorrhage after direct pressure, optimal use of vasoconstrictors, cautery, and anterior packing, this suggests, but is not diagnostic of, a posterior bleed. Another thing that you can try, is worth a shot, Dr. Brown also mentioned this, is bilateral anterior packing. Sometimes a little bit of pressure from the other side can actually help slow down that bleed. So either way, if there's a posterior bleed, you're going to need ENT. But in the meantime, you can apply the posterior packing as the method that I showed you earlier. And just remember, there are risks with this. There is risk of pressure necrosis, infection, even cardiac dysrhythmias, according to Tintinelli. So just try to minimize, hopefully, the time somehow from the time that you apply the posterior packing to when they actually get transferred out. And that is it for this JG Extra. So thank you.